All right, so I'm going to talk about disaster planning. And disaster planning, we always want to plan before a disaster happens. And in fact, the Joint Commission dictates that hospital systems do practice disaster planning because you don't want to figure out in the middle of a disaster, you don't know what you're doing. So, a disaster is any event that causes the resource capabilities of the healthcare system, they get too stressed, okay, and they can't handle it. So, um, now, a mass casualty event is an emergency in which the number of victims overwhelms the human and material capacity that's available. So it's usually associated with like a wildfire or an industrial accident. Now, when something like that happens, disaster or mass casualty, government agencies do come to help for disaster planning, and there's a few of them that do come to help. Um, but when something like that happens, it's really everybody's responsibility to help um, mitigate the disaster and take care of people. Okay, so hospital preparedness, I talked about that. We always want to be prepared before a disaster happens. When a disaster happens at the hospital, you may be asked to do reverse triage. And what reverse triage means is that you may have to, as a charge nurse, choose which patients can leave the hospital to open beds for those that need them. Okay, so patients that wouldn't be discharged would be, of course, somebody in a critical condition. Anybody that's awaiting tests, like I come in with a cough and a fever, and I'm waiting for my sputum cultures to come back. Anybody bedridden, unless they're going to a facility that can handle them. Okay, so disaster preparedness and management is everybody's responsibility. Now, as a nurse, your textbook points out that we all need to be ready for a disaster, which I am not. I do not have a go-to bag. Okay, but you are supposed to have a go-to bag ready to go. And what goes in that bag is not everything you own, right? Just what you're going to need in an emergency. So you're going to need water, you need batteries, a flashlight, your phone, charger, um, non-perishable food. Make sure you bring extra clothes, especially if you live in a place that's cold. And if you're on medications, of course, you would take those. And any important papers, but not like every paper you have in your house. There's usually, after a disaster, there could be people that are involved with caring for people, or even people in the disaster may suffer from post-traumatic stress disorder. So they that you should be monitoring for those signs after a disaster. Okay, now this students usually catch on to this really quickly. I don't know if you've had this before, but triage means to sort, right? So if there's a natural disaster or a mass casualty event, you may have to help with military triage. And military triage is a tagging system. So we're going to tag our patients that we find in the field with different colored tags. That means something. I'm going to explain that in a minute. But the reason we do this is so we can do the greatest good for the greatest number of people, because we can't save everybody in a disaster. And this is sometimes hard for nurses to understand. So we don't confuse this with civilian triage, which is like you go to the ED and the triage nurse sees you first. Okay, so it's different. I'm going to explain that in a minute. So somebody that's going to be tagged as a red tag, this means emergent. They need immediate care, the highest priority. They cannot wait. A yellow tag means they can wait for 30 minutes to up to about 2 hours. So they can wait for a short amount of time. Now, if they're not seen in that time, the injuries may become life-threatening, but they can wait. Green tags are your non-urgent or your walking wounded people, which is going to be the majority of the people you're tagging. And they're going to be the ones that overwhelm the system, okay? So they're also called walking wounded. Your white tags, now your textbook is the first textbook I've seen that has a white tag category. Most just have 4 categories. So this is for minor bruises and abrasions, so it's minor injuries. And then black tags are expectant to die or are dead. Okay. So we got to figure out who goes in which category. So remember, in any case, in any disaster, any emergency, if you stop on the side of the road, we always must practice within our scope of practice. So that means if I see somebody that is not breathing and I think their airway, their upper airway is obstructed, I cannot do a tracheostomy because I have not been trained for that, and that is not within my scope of practice. Okay. Now I could tag people. I can do some things like put in IVs, hold pressure on bleeding, somebody that's hemorrhaging. I can do those kind of things, but I can't do surgery. Okay, people that are red tagged, just to give you examples, because you might have to tag people, okay, would be somebody with airway obstruction or neck and facial swelling, anybody in shock, okay, and we're going to go over shock too. Anybody with severe chest pain, anybody cool and clammy, no matter how old they are, rib fractures, shortness of breath, sucking chest wounds. Okay, these people would be red tags. See, they're mostly airway and breathing problems. They need to be seen right away. Somebody was hemorrhaging, they would need to be seen right away. You would need to help put pressure on that. A yellow tag, this could be like open fractures or partial thickness burns, large abdominal wounds that's not hemorrhaging. Okay, that would be an example of a yellow tag. Green tag is like broken fingers, simple fractures, lacerations. Black tag, this would be like a high cervical fractured spine. It could also be, you see somebody Chain Stokes breathing. That could be a black tag. You see somebody that has gray matter coming out of their skull. That could be a black tag. Somebody with full body, full thickness burns. That would be a black tag. Okay, so those are some examples of black tags. So how this is different than civilian triage is if somebody comes into your ED and you look at them and you think they're going to die, you can't say, well, I'm not going to be able to take care of you today because you're expected to die, right? You can't do that in the hospital system. All right, so this is military triage. Okay, let's talk about the types of disasters there are. So there are man-made versus natural. I think you can figure this out. Man-made is something that a human did, right? Bioterrorism, arson, what else? Let me see, chemical spills, nuclear power plant explosions. Those could all be human made, okay? And then the natural things like the earthquake and the hurricanes and snowstorms, um, so those could be detrimental. Okay, so a chemical disaster, you're gonna have to like kind of know these qualities of a chemical disaster, so you can know how to spot it. So it is difficult to identify, but usually there's like a fog or a cloud, like a low-lying cloud, and there may be some funny smells in the air, like it might smell like mowed grass and there's really no grass that was mowed. So that may be something you might pick up on. People are, you find people are dying downwind to a new fog in the area. That could be a tip off. Um, what you need to tell patients to do or people to do is close all their windows and stay indoors. Like they have to stop up their, any vents. You don't want air from the outside coming in. With a nuclear disaster, I think I mentioned it's mostly from some type of explosion. So patients will be treated with chelating agents. And these chelating agents bind with the radioactive material from the nuclear disaster and allows excretion before the body or the tissue absorbs it. So that's important. That would be a treatment for that. And then signs and symptoms of radiation sickness, because as an ED nurse, when people are coming in, you have to recognize these signs and symptoms. Okay, so it's damaging to the bone marrow. So they're going to have low WBCs, which is leukopenia. They'll have bleeding because their thrombocytes are not going to work. They're going to, GI, they'll have nausea, vomiting, and diarrhea because radiation is toxic to the GI system. They'll lose their hair, and they may become very confused and have seizures. So that's radiation thickness. And then with bioterrorism, what bioterrorists do is they kill your food supply. Okay, so you might see like farm animals dying or a lot of animals dying on the side of the road. There might be a large number of patients presenting to the ED with the same signs and symptoms. So that could be a tip off, especially if you think it's a food illness, because bioterrorists, love to put bugs in food. There's categories A through C. Anthrax, I think, would be the most highly tested. It's a category A, and the reason it's category A is because it's easily disseminated. With anthrax, it's not spread person to person, like it's not contagious. Like you couldn't catch it from me, but the reason they use anthrax, it's airborne, so they can disperse the spores into the air and you breathe it in, it comes into my alveoli and starts multiplying. So that's why it's really um, an easy, uh, bug to disseminate. So that's why it's there. Now, anthrax does have a vaccine, and it does have medication like Cipro treats anthrax. But they don't give the vaccine, they're saving it until I guess we need it. Okay, now we're going to talk about civilian triage and trauma. So there's something called pre-hospital care, and I don't know if you've ever come across an accident, or your neighbor has a question for you or something like that. So this is pre-hospital care, which includes like accidents, poisoning. We are covered by the Good Samaritan law as long as we practice within the scope of our practice and we have good faith when we're taking care of people. Okay, the first thing you're going to do if you come across an accident, right, you have to save yourself first. You're going to survey the scene, make sure it's safe for you to help the person, okay? You never want to remove impaled objects. So, like if somebody had a knife in their chest, you would never want to remove that because if you remove that, you can cause hemorrhaging. So, you don't want to do that. So, we always leave objects where they are, okay? Diving accidents, okay? So, do not remove somebody that you think had a diving accident, like they maybe had a spinal cord injury when they dove into shallow water from the water. What you want to do is immobilize that head and neck and keep the face above water if you can. Only remove from water if they're not breathing, then you're going to have to do rescue breaths, okay? Choking. If a patient is talking, they are not fully choking. So encourage them to cough and deep breathe. And then if they were choking, you would ask, can I do the Heimlich maneuver? And you would do it. I cannot believe how many people actually do choke on meat. Like working in endoscopy, number one thing you're called in for. Somebody's got a bolus of meat in their esophagus because they didn't chew their food good enough. So it's really common. With motor vehicle accidents, you are going to move the patient only if it's unsafe to leave the patient. Okay, so like some examples would be if there's pooled gasoline on the ground because that could light on fire. If the car is submerged in water or snow, you would want to get the patient out of there. And the reason we leave the patient where they are is because we don't want to cause a spinal cord injury. Okay, but if they're going to be in danger, then you need to move them. If the patient is laying on hot pavement, they can get really bad burns from that. So you might move them in that case. And if there's oncoming traffic, you might have to move them because the traffic may hit them and then they could be really in trouble. Okay, now with poisoning, the number one thing you want to do if you come across somebody that thinks they were poisoned or they swallowed something they shouldn't, okay, call the poison control center. Name the poison. You're going to give the name of the poison if you know it and give the patient's age, weight, medications, and medical history. Never induce vomiting unless you're instructed to do so because there are a lot of poisons and chemicals that can cause damage to the esophagus. So you never want to bring something back up that is going to cause damage. Okay. Now, with ED care, the nursing care is episodic. And what I mean by that is The patient comes in, they get treated, the ED nurse stabilizes and gets them to wherever they need to go in the hospital. And that's best practice. They need to be in and out of the ED within 90 minutes. They shouldn't be there that long, okay? Because they'll get better care when they're being taken care of nurses in that specialty. Like if they need to go to ICU, the ICU nurses can now care for them. So it's really important to get them out of the ED as quick as they can. All right, so ED nurses follow medical protocols. And what I mean by that is if I have a patient that comes in with chest pain, I know I got to get an EKG in 10 minutes. I got to draw all those labs. I'm going to start an IV, so they don't wait for a physician to see the patient. They already know based on the patient's symptoms what they're going to do next. All right, and it's cradle to grave, so you have to have a wide base of knowledge to work in the ED because they take care of very little babies to the very old. And most of the care is acute or critical care in the ED. Okay, if you come across an accident and somebody's got abdominal viscera exposed, or they're in the ED or they're in the hospital room, make sure you stay with the patient. You're going to get saline soaked gauze and keep that moist until they can get to the OR. Okay, keep the viscera moist. All right, conditions that result from chest trauma. Okay, so death, number one, rib fracture, flail chest, pneumothorax, hemothorax, and tension pneumothorax. Now, I'm only going to give you like really snippet of this, okay? Because I anticipate if you get questions about this on NCLEX, I'm going to give you some tips because I think I know what they're going to be. And I think hemothorax may be on your proctor because I think I saw a question about it. So I'm going to give you some key points here. So flail chest is something that can happen in a motor vehicle accident or any type of accident that involves trauma to the chest. Okay, so what happens is the ribs get fractured and they have on both sides. Like this side gets fractured and this side gets fractured. So this little free floating segment here. And the word you're looking for is paradoxal chest movement. Okay, so when the patient breathes in, if you breathe in, your chest goes out, but this segment will go in. Okay, so paradoxal movement. Treatment is the same of rib fractures. So with rib fractures, you just treat symptomatically. So head of the bed up, no binding the ribs at all because they're not going to breathe. And you need to make sure they're well medicated because they're not going to breathe because it's very painful to have rib fractures. And then O2, of course. Okay, pneumothorax. A pneumothorax means there's air in the pleural space. So something happened and we call it a drop lung. If you can see, this lung is tiny. This is the pleural, right? And this is air in the pleural. So here's another picture of it, what it looks like. So there's air here, okay? But this air doesn't move, so you're not going to hear lung sounds in this area where they have a pneumothorax, okay? With a hemothorax, they're going to have blood in the pleural space. So here, this could happen with trauma, okay? Here's an example of that. There's blood in the pleural space. Since there's no air movement, you're not going to hear lung sounds if somebody has a hemothorax, okay? A tension pneumothorax happens in trauma when there's a sucking chest wound. The air goes in through the wound, but it can't get back out. So what happens is all this air collects in the dropped lung and it starts pushing the great vessels in the heart to the other side. So what you're going to see is a deviated trachea to the unaffected side. So if you look here, this air is going in, okay? So this lung has dropped. Okay, the air is going in, but it's not coming out. So it's going to put pressure and everything is going to shift to the other side. Okay, so the signs and symptoms of these hemothorax, tension hemothorax, and pneumothorax, okay, they're going to have pleuritic chest pain, which means it hurts when they breathe. Okay, they're going to have dyspnea, feelings of impending doom, and then shock-like vital signs. So shock-like vital signs, they're going to have tachycardia first. So tachycardia is a sign that our bodies are stressed, and it's often the first sign of many conditions. So if your patient has tachycardia, you need to investigate. tachypnea, and then low BB happens a little bit later. This is cardiac tamponade. This could happen if somebody hits the steering wheel with their chest with the steering wheel, or somebody could get stabbed, and it could cause cardiac tamponade. Around your heart is a pleural sac, okay? So if they get blunt trauma, there may be bleeding into the pleural sac, or they may have swelling. In any event, it makes it so the heart can't beat because this pericardial space, sorry, is it gets tight, so the heart can't beat like it wants to. Okay, so you may see or hear muffled heart sounds, JVD. Now, cardiac tamponade has what's called a paradoxal pulse, and that's all you really need to know because that's the terminology they use. It's paradoxal pulse. Okay. Um, Conditions that require intubation. Now, this is important because we talked about these kind of conditions throughout the semester. So, it's important to kind of review what you've already learned, okay? So, remember we talked at the beginning of the semester about Guillain-Barré syndrome, and this happens usually a young kid like 24, 25, or young adult, I guess I should say, and they had the flu, or they had a flu shot, or they had some kind of virus, and then 6 weeks later they come in complaining of paralysis, they have weakness. When it gets to the waist, okay, it's time to start thinking about intubating, okay, because they're going to need to be intubated for a time. Remember, that's self-limiting. They get intubated, they can be intubated for a couple weeks, and they get extubated, and they're fine. They never have a problem again. Okay. Anybody with a Glasgow coma scale less than 8, we intubate. Anybody with inhalation injuries is going to be prophylactically intubated after they come to the hospital. And then remember we talked about thyroidectomy or parathyroidectomy. A couple of things. It's surgery on the neck, right? So they could get really swollen. Also, they get a low calcium, so they could have stridor, right? So they're the ones that need the trach tray at the bedside, okay? But that may need to be done if they have trouble. Now, I'm going to teach you some abdominal signs. We've learned these before. So abdominal signs are Cullen sign and Gray-Turner sign or Turner sign. So Cullen sign is around the umbilicus, and it indicates intraperitoneal bleeding. And then Gray-Turner's is on the flanks, and it indicates retroperitoneal bleeding. If somebody has a positive Kerr sign on the right, Kerr sign means they're complaining of pain in their shoulder. So if they have a positive Kerr sign on the right, it means they probably have liver trauma. So that's a bad sign because the liver is highly vascular. Remember when we talked about liver biopsy and you have to put them on their right side to make them stop bleeding, okay? Because the liver is highly vascular, it bleeds easy. So if they have pain in the right shoulder, they probably have liver trauma. And if they have pain in the left shoulder, they may have ruptured their spleen. Okay, so those are important signs. And then we also earlier in the semester talked about traumatic brain injury and basilar skull fracture. So you're going to look for the raccoon eyes and the battle sign, which is bruising behind the ears. And you're going to check the ear drainage or nose drainage for glucose and halo sign if they have any. Those are important points. All right. We also talked about stroke patients earlier in the semester. So if somebody comes into your ED and they're suffering from aphasia, make sure you're using your normal voice. Take your time because people with aphasia get very frustrated because they can't talk. Ask yes or no questions. Make sure you're speaking slowly in your normal voice and face the patient. Be patient and allow the patient to respond, okay, and use nonverbal gestures, but be aware of nonverbal cues you're giving off, especially like if you're working in the ED and you're, in a rush. You don't want to give off that vibe that you don't have time for them. I think this may be a proctor topic. It's about which area of the brain are you going to see with different kinds of aphasia. So Broca's aphasia or area is on the frontal lobe. And these people have Broca's aphasia, cannot talk. they can understand you but can't really talk. On the other hand, Wernicke's aphasia, Wernicke's is on the temporal lobe, okay? So patients' speech is normal and excessive, but they really don't know what they're talking about, okay? They're not making any sense, okay? So that's the difference between those two. And then if your patient has a mild TB, a traumatic brain injury or concussion, you need to report a change in the LOC or pupils, because remember, a change in the LOC is the first sign of increased intracranial pressure. Pupils comes a little bit later. Tell them to come back to the ED if they have vomiting, loss of balance, extreme headaches, and weakness, any kind of neurological signs. In the ED, the most common metabolic emergencies you're going to see include hypoglycemia, thyroid storm, Addisonians, DKA. So hypoglycemia, remember we talked about this in the diabetes lecture. So remember the signs and symptoms: blurred vision, tachycardia, irritability, restlessness, excessive hunger, and diaphoresis. And then with Addisonian's crisis, remember they get low, everything's low. So hypotension, weight loss, hypoglycemia. They will have a high potassium and a low sodium. So they need steroids. And then Cushing syndrome, remember that's the oversecreting of the glucose steroids. So they're going to have high sugars and low potassium. And they're the ones that have like the buffalo hump and the striae on their belly. So DKA, the treatment of DKA is IV fluids, regular insulin. Remember, when you give regular insulin, it pushes potassium into the cells. So teach your patient to check their blood sugars frequently to prevent another episode, especially when they don't feel well. Okay, now the primary survey. This is the kind of triage we use in trauma. It can be used in the ED as well. So it's called the ABCDE method. Okay, so with A stands for airway and cervical spine. B stands for breathing. C is circulation. D is disability. And E is exposure, okay? The nurse can remove the cervical collar when the physician or provider has looked at the x-rays and told you you can remove the collar, okay? Because they have to make sure that the spine is not fractured in any areas. Okay, so we're going to go over the primary survey now. So A is airway and cervical spine. Anytime you have head injury, you look for spinal injuries. And anytime you have spinal injury, you look for a head injury. So anybody with a TBI or has like massive trauma is going to come in with the cervical collar on, okay? So some of the assessment findings you may find in somebody that's having a problem is inability to vocalize. If they're not talking, their airway probably isn't patent, okay? They may have dyspnea. So your highest priority is getting the airway open. And if you have somebody with a cervical spine, you use the jaw thrust maneuver, okay? And then with breathing, breathing refers to the movement of air, like ventilation. Is the patient ventilating? So you take your stethoscope and actually put it on the lungs to make sure they're breathing. Because when I worked in PACU, that's what we did. And the reason we did that is patients can move their chest up and down, but there may not be air moving in there. So you have to check for air moving, okay? And then you're going to have to bag them if they're not breathing properly. Circulation, okay, so make sure, check if they're bleeding anywhere. One of your priorities as an ED nurse, if somebody's going to need a lot of fluids, is get 2 large bore IVs in lickety split, like right away, get that in. D is for disability, and this is a rapid neuro assessment. You can use the Glasgow Coma Scale. You can use what's AVPU. Don't memorize that, but it's just another way that they assess a patient really quickly. And then E is for exposure. So in E, you're going to take off any clothing. You're going to maybe even cut it off, right? Especially if it's wet. You need to prevent hypothermia at this stage. So they may be using a bear hugger. I don't know if you've seen one of those, but it's like warm air into a blanket that you put on your patient. So we call this strip and flip stage. So what you're going to do is you remove the clothes and then you get 4 or 5 people and you log rolls just really quick. And all you're looking for is on their back to see if they have anything impaled. You're looking for bruises. You're looking for cuts. You're just looking, okay? You're not really doing anything yet. Put them back down. All this, the primary survey takes 60 seconds to complete. So it's really not long at all. And when you come back to the ADM program, I'll teach you all about the secondary survey and what you do for that. But for right now, the primary survey is really good for you to know right now. All right, we're going to talk about some environmental emergencies. So the vulnerable populations, we'll talk about heat-related emergencies first. So usually it's the very young and the very old that are going to be prone to heat-related illnesses. Anybody that works outside, anybody that works during the day, athletes that are, working out in the sun in the middle of the day, which they shouldn't be, but they're going to be at risk. Okay. So to prevent heat-related illnesses, do not drink alcohol and caffeine. Okay. Avoid sugary drinks like soda. Like this is important information to give patients because a lot of people do drink alcohol, like if you're on the beach, right? And everybody loves caffeine, at least I do. Avoid sugary drinks like soda. Drink before you're thirsty. Make sure you're using sunscreen and also wearing like protective clothing when you're outside. Rest frequently. Limit your activity during the hottest part of the day, like don't go for a run at noon in the middle of the summer. Wear lightweight, light colored, loose fitting clothing. I see people like trying to sweat it out with like black, like sweats. Don't do that. Wear lightweight, light colored, loose fitting clothing. Make sure you exercise or work early in the morning or late in the evening after it cools down. And we're going to talk about heat stroke. So heat exhaustion is a little bit different than heat stroke. Heat exhaustion is like really just being dehydrated, okay? But when somebody gets heat stroke, there are some characteristics you need to know. So the temp is greater than 104. They're going to be tachycardic, tachypnic, and have low blood pressure. The cardinal sign is the patient gets confused. That's how you like really know it's heat stroke. They're not going to be sweating. You need to keep them NPO so they don't aspirate. Okay, heat exhaustion has excessive sweating. That's why they get dehydrated. And they're going to have muscle cramping. So that's kind of the difference between the two. Snake bites. If you have somebody that gets a snake bite, don't apply ice or a tourniquet. You want to splint the area, and the reason you splint the area is to minimize the movement. Okay, so the venom doesn't circulate around. Place the limb, if it's a limb, I'm assuming it's a limb, at or below the level of the heart. Do not elevate. No NSAIDs and remove jewelry and tight clothing. Okay, older adults are at risk for hypothermia. So the reason is that they're not as active, they have a low metabolism, and they have less subcutaneous fat. Okay. So to prevent hypothermia, you're going to tell people to move and exercise. You want to layer clothing. Tell them to wear hat and face mask. Hat is good. Hat keeps a lot of heat inside. Sunscreen and sunglasses at all times, even in the cold weather. People should not restrict food or fluids, so they should eat high energy foods if they're cold. When you eat, it increases your metabolism. So that's going to hopefully make them warmer, and no alcohol. All right, the signs and symptoms of hypothermia. They're going to shiver, and shivering is a good thing. If the patient stops shivering, that's a bad thing because that means they've gone to a different level of hypothermia. So with a mild level, they'll be shivering. They'll have dysarthria, which means slurred speech and decreased muscle coordination. So it's almost like they're drunk, the way they present. Impaired cognition. So if they stop shivering and they get really lethargic, that means they've gone to moderate and possibly even into severe level of hypothermia. All right, frostbite. Now, a frostbite is an injury that can happen from being out in the cold. It's really a burn, and it's a burn injury to the tissue. So it's freezing of the tissue fluid. It's so cold out that like the fluid in your tissues freezes, and it's extremely painful. Okay, so you're going to have to know the difference between second degree and third degree. So second degree is going to present with milky blisters and be red. And that should be easy for you to understand because that's the same as superficial partial thickness burn on a burn. Okay. Third degree burns are blood filled blisters and they have black eschar. So that's a full thickness burn. Okay. All right, treatment is going to involve rapid rewarming and warm baths. The bath can be like 104 degrees, so you need to like really medicate them with IV opioids. They're going to get NSAIDs around the clock to decrease the inflammation, but they really need the morphine or some kind of opioid before that's done. Never massage somebody with frostbite or use like a heating pad like dry heat. Okay, assess the 6Ps because they could get compartment syndrome and you don't want that. So make sure you know how to look out for that. And then they'll need a tetanus shot, like just like snake bite is going to need a tetanus shot. Anybody with burns coming to your ED is going to need a tetanus shot. Um, so it's something we always assess for. All right, then with shock. So shock is a syndrome of inadequate perfusion. And it means it happens if somebody's mean arterial pressure gets below 60. Okay, so you never want to see a mean arterial pressure below 60 because that means your vital organs are not being perfused. If it's not treated, it's going to result in multi-organ system failure and it's going to lead to death. Okay. So there's several different types of shock and they all present a little bit different, but I'm going to give you the commonality of signs because that's the way you're going to recognize it. The first sign in shock is always going to be tachycardia, except in neurogenic shock, it'll be bradycardia. They'll have tachypnea, then hypotension. Now, hypotension doesn't, it happens after somebody's had tachycardia and tachypnea. So they may have postural hypotension as well. Then decreasing LOC, your brain gets 25% of your cardiac output. So if your heart isn't pumping efficiently, right, like with shock, you're not going to get oxygen to your brain. So you're going to have a decreased LOC. They'll have a paralytic ileus because anytime our bodies are in shock, like with burns too, that the gut gets turned off, okay, because we got to save the blood for vital organs. They'll have increased glucose even if they're not diabetic because of the stress response, and decrease urine output and a lactate level greater than 2. That's important. Okay, so those are the signs and symptoms of shock. Okay, now trauma nursing. Okay, so this is the same thing I just went over, and this is a secondary survey. You don't really have to know that. I just wanted to show you one thing over here. This is, and you don't really even have to know this. This is just interesting. With people that have abdominal trauma, they're going to get a focused assessment sonography for trauma. So it's like an ultrasound. They just bring it over bedside and they look for chest injuries and also abdominal injuries. Okay. So this is how they would find some injuries in here. Okay. So that's just interesting. All right. Now I went over all the ED and trauma. Do you want me to go over anything else? Like, do you want me to go over the skin? Anybody? Yes.
Yes, I
Oh, can
put
you hear
yes in
me?
the chat.
What's that?
Can you hear me?
I can hear you now.
Okay, thank you. Can you go over real quick? So, what is the Cullen sign and the Gray Turner sign? What is that?
Yes. So Cullen sign, you learned about that when we did pancreatitis. Okay, because people with pancreatitis get that sign. So
Okay.
if you look at, let me see where it is, the picture. Okay, right here. So it would be bruising around the umbilicus is
Oh,
Cullen
okay.
sign.
Okay.
And then bruising on the flanks is Gray Turner's. And they both indicate like some kind of bleeding in the abdominal cavity.
Oh, okay. So the Kerr
So that's something
sign,
you would be.
uh-huh,
Kerr sign, Kerr sign is pain in the shoulder. So
in
if
the
it's on the
shoulder.
right side, you think liver trauma. 'Cause remember when we did like cirrhosis and people getting liver biopsies, you have to put them on the right side to stop the bleeding because the
Oh,
liver's
yes.
so vascular.
Okay.
Yes. So like the liver's really vascular. So if somebody has liver trauma, it's going to press on the nerves and it's referred pain. Like her sign is referred pain.
Okay. Got it. Okay. All right. I understand now. Thank you. And yes, go
You're
over the
welcome.
skin and whatever. I don't care. Just go over
Okay.
everything. Thank you.
All right. All right. Let's talk about pressure injuries. I am going to try really hard not to say the word ulcer, but it is really hard after all these years of being a nurse. They keep changing this name on me. All right, so the risk factors for pressure injuries, and I'm hoping this is a review for you from fundamentals. Um, in people that are immobile, incontinent, they can't take care of themselves, they have decreased LSC. Anybody with malnutrition, anybody with diabetes, because the sugar blood, the bugs just love it. Anybody older, and shearing. So um, shearing has to do with how you move your patients in bed. So, like, for example, if you slide your patient up in bed, you cause a shearing injury. That's why you always want to lift your patients up to move them. Don't let them scoot up, like slide up in the bed. All right. To prevent, you want all surfaces to be smooth. Like, you don't want your patients sitting on like a wrinkle. Okay. Keep moving. Patients need to get up and move around, not be sitting on their butt in the same place all the time, right? Incontinence management. I know you're busy, but patients need to be cleaned up as soon as possible. Good nutrition, protein and vitamin C help with collagen synthesis. So it's important for them to eat high quality protein and get vitamin C sources. You want to turn your patient's Q1 to 2. Don't let them slide in the bed. You must lift. That's what I was just talking about. Use positioning devices like wherever you work. If they have like a Hoyer lift, make sure you're using it. Um, I don't know if you've ever seen like orange plastic the, tubes that you can like pull patients up in bed. But any kind of repositioning device that your organization uses, you should definitely make use of. Okay. You want to clean skin with warm water and mild soap, and then apply moisturizer after that, but not between the toes. And then wheelchair users should shift their weight every 1 hour, but every 15 minutes is even better if you can. You never want to use a donut foam. A donut foam looks like a donut. Okay, it was a pillow. We used to put people, like, I started working in a nursing home when I was 16, and this is what we used to put people on, these donut pillows, and we thought it was saving them for coccyx, ulcers on the coccyx. But what we ended up doing is giving them ulcers on their sacrum. So we don't use those anymore. No sitting on donuts. Never massage bony prominences because it impedes the blood flow. And you always want to encourage the use of trapeze because we always want our patients to be independent as much as they can. It helps us and it helps them feel better about their, disease. Nutrition, I talked about protein, vitamin C, zinc, vitamin A and E. Those are good. The scales, you probably learned in clinical about the Braden and Norton scale, and these are just scales whatever your organization uses. You want to make sure you're tracking it, and it helps predict risk for skin injuries. And then the stage system, you're going to have to know the characteristics of these stages. So there's one called suspected deep tissue injury. And so this is just intact skin with a purple or maroon discoloration. But um, these other stages you're gonna have to know, okay? So stage 1 is the most superficial, and you can see here the area is red. It doesn't blanch. It's deep pink or mottled, okay? The next area is a partial thickness injury, and it involves the epidermis or the dermis or both. So the skin can be blistered or abraded and has a shallow crater. And you can see here, right here, that's like a shallow crater, like craters like edges, like you can see it's shallow there. And it may feel like hot or warm around the edges of the wound. Okay, stage 3. Okay, so this is ulcerated, so it has like a crater right here. That looks like a crater. Okay, so the subcutaneous tissue is involved and it may be infected. So most stage 3 ulcers are infected. They may have undermining, and undermining is like you have like a ledge of skin and there's like a tunnel underneath it. And I have a picture of undermining in the Quizlet if you want to take a look at that so you can see what that looks like. It has full thickness skin loss. And then with stage 4, there's going to be deep ulceration. This goes down to bones and tendon. Um, you're going to see the fat here. So the ulcer can be dry, black, and necrotic. So, and you can't tell what the depth is. So if you come across somebody that has a new pressure injury, get the before you do anything else, get the patient off that area. Okay, so you don't want to add more injury. Measure and document 1 time a week. I mean, of course, you're going to assess more times because you're probably doing some kind of treatment to it, right? But you have to do a really like a wound nurse do like a really in-depth measuring, taking pictures, documenting. All right, the treatment. Okay, so debridement to remove eschar, so that can happen. The debridement could be surgical or mechanical. Surgical debridement could even happen at the bedside for somebody like diabetic. When I was in nursing school, this was a long time ago, I saw a surgeon debride somebody's black ulcer on their foot. No pain medicine. I just could not believe it. He was like just away at that skin, the black eschar coming off that ulcer. The patient like didn't even feel a thing because he's diabetic. Or they can do like mechanical debridement with hydrotherapy. Um, I don't know if this is caught on everywhere, but wet to dry dressing are no longer recommended. I don't know if you're familiar with that term because as you pull the dressing off, you're breaking the new granulation tissue that has just been trying to grow. So it's not really good. All right, viral infections of the skin. About herpes simplex and herpes zoster. So with herpes simplex, it is the type 1 lesion is an oral lesion. You might see them on the nose, the oral cavity. And type 2 genital. If somebody doesn't take good care, like good hygiene, they could put a type 1 lesion on the genitals. Like look at ulcer that person has. She could touch the lips, and then if she was using the restroom or something, could inadvertently transmit that somewhere else. So that's where you usually see it. But just so you know, you have to teach people that do have herpes simplex really good um, hygiene. So the things that bring it on are like exposure to the sun, skin irritation, they get sick, or stress or fatigue. So the assessment findings, usually patients have like a little burning in the area before it was itching, and then the contagious period is up to 5 days after the outbreak. So patient teaching involves a good hygiene. Then they topical or oral antiviral medications. So they have like creams like a cyclovir cream, and they have oral medications. So with herpes zoster, now herpes zoster is caused by the herpes varicella zoster. zoster virus. So it's the same virus as chickenpox. It just gets reactivated. So it lives like in a peripheral nerve ganglion and it stays dormant until your body gets reactivated, like with extreme stress, or people with HIV, people that are immunosuppressed, like radiation, malignancy, um, stress, so they can get herpes zoster. So it's called shingles. Now, I want you to look at this gentleman here. Okay, see how he has it in his chest in this pattern, and it's on one side of his body. That's a telltale sign. The blisters are on one side. It follows a nerve root, so that's why it's in this shape right here, and it doesn't cross over to the other side. So that's another telltale sign. So you could see them like on the torso or on the face, on the neck. So, but again, it doesn't cross over. So the assessment findings of the person, first of all, this is extremely painful. And you want to help with the pain because they can develop post-herpetic neuralgia, which is it's a chronic condition, extremely painful. So the assessment findings include fatigue, low body fever, so almost like a flu-like before the blisters start. Anorexia, blisters on one side of the body that follows a nerve pathway, and severe pain. The treatment, if somebody does have this, they're going to need to be on both airborne and contact precautions until the lesions crust over. They're going to be given analgesics, antivirals, and corticosteroids. Now, the corticosteroids are going to be PO. Remember that. Same with antivirals, could be IV or PO, and analgesics PO. Okay, but no, I'm just trying to point out with the herpes simplex. Okay, it's simple, so they can use like topical um, treatments. Okay, skin cancers. Okay, so the number one risk factor is spending a lot of time in the sun, especially if you are blue-eyed and have red or blonde hair. Okay, light complexion. Sunburn as a child is also a risk factor. So there's three main types of skin cancer. There's basal cell, squamous cell, and melanoma. And really, they're all treatable, put it that way. They could have good outcomes, but the problem is you have to find it early. Okay, so with basal cell carcinoma, okay, so this is a small scaly lesion. It doesn't metastasize, but it can invade the tissue, resulting in death. Okay, squamous cell, this is from being out in the sunlight, usually on the head and neck. That's where it appears, and it affects the epidermis, and this can metastasize. With melanoma, this is the least common but most deadly. Look at like all these different variations. Like this looks like a blackberry. This is notched. This has like black patches in it. So they all have like weird, like irregular borders. Um, there is a genetic disposition to melanoma, and it's caused by solar radiation, so being out in the sun. Superficial lesions can be cured, so they can. I had a friend when I started my nursing practice with her, and she had a mole that turned itchy, and she had somebody in her family with melanoma, so she knew that she needed to go to the dermatologist, and they did a punch biopsy, and then after that they did a surgical excision, and that was 36 years ago. So she's doing fine. So that was kind of scary for her that she had melanoma. Um, and just look for those notched areas on the moles. All right, let's just backtrack to burns, okay? So with burns, um, let's talk about a couple things about the type of burns, okay? So the thermal burn is going to be the most common type of burn. Chemical burns need to be irrigated a lot. Like you could be like 2 hours irrigating a chemical burn. Electrical burns, okay, so with electrical burns, the problem with electrical burns, or I should say they're deceptive because it's going to have an entrance wound and an exit wound, and they're not going to look bad. The problem is, as the electricity passes through the body, it wreaks havoc. It causes all kinds of damage. So all the cells are lysing, okay, the muscle cells. So potassium leaks out of the muscle cells, myoglobin leaks out of the muscle cells. So you need to make sure your patient is on telemetry. They need to have an EKG, um, and check and make sure their kidneys sitting there putting out urine, because all that myoglobin is going to cause a kidney infection. Okay. And they could go into VFib up to 24 hours after, and you don't want that. Okay. Smoke inhalation, three types. I'm going to talk about them later. Um, Metabolic asphyxiation. This is inhalation of carbon monoxide. Could happen if somebody has a burn injury, like indoors or in a burn accident. Um, so the signs and symptoms. Okay, carbon monoxide is a vasodilator, and if you can remember that, it's going to be easy for you to recognize the signs and symptoms, because as we dilate, more color comes to our skin, right? So they could have like cherry red skin, they could have cherry red lips, they could have headache, because when you vasodilate the veins in your head, you're going to get a headache, dizziness, nausea, confusion as well. The treatment for carbon monoxide poisoning is 100% oxygen. The ABGs in the O2 sat in carbon monoxide poisoning are not reliable. And the reason they're not reliable is that carbon monoxide has a higher affinity for the red blood cell than oxygen does. And all that is to say is that carbon monoxide basically kicks oxygen off the red blood cell, but it shows up on our readings as oxygen. That's it. So the treatment is 100% oxygen. Make sure you can recognize it and remember the little tips I gave you here. Um, okay, full thickness burns um, burn the subcutaneous layer of skin, which has nerves and sweat glands. So after somebody has a burn, like in that area that's full thickness, they're not going to have they're not going to be able to feel it, okay, and they're not going to be able to get rid of excretory, like sweat, okay, they're not going to be able to sweat. Okay, smoke. I just talked about metabolic asphyxiation. ABGs are unreliable. CO2 is a vasodilator. Remember those signs and symptoms and treat with 100% oxygen. Now, if somebody has an upper airway injury or a lower inhalation injury, they need to be prophylactically intubated. Lots of signs and symptoms. Anybody with burns on their face, you need to be checking for these. So look inside their mouth in their nose, look for singed hairs, look for like smoky breath. Look, see this? That's like soot. Okay, so look for things like that. Also, if they have uh, carbonaceous black sputum, that's a tip off that they have an inhalation injury. Okay, brassy cough is like a croupy cough. So, Strider, I think you can figure that one out, but they're going to need to be intubated. See how puffy he is right here? So what happens is when you have a major burn injury, you have the systemic reaction at the burn site, but you have a all over body reaction. The capillaries all over the body get leaky, and all your fluid starts leaking out to the tissues. Okay, burn depth. You're going to have to be able to distinguish the different types of burn depth. So superficial is like a sunburn. An example of somebody would get, laying in the sun using heating pads or aquathermic heating pads. So the color will be red to pink and it blanches. Mild edema, a lot of pain, no blisters. Okay, so that's important because the only burn that really blisters is partial thickness superficial. So if you see blisters, be thinking partial thickness, superficial. So partial thickness, superficial, is going to be pink and red to blanch, and it does blanch. Students get this confused with superficial, so make sure you can distinguish between the two. They're going to have mild to moderate edema. So the edema goes up with each level, okay? And then it's finally severe here, but then it's absent after that, okay? So it depends on how you like to learn, how you're going to like learn this chart. So um, they're going to have pain. So the more superficial the burn is, the more pain it is. Okay, because that's the nerve endings are still intact. All right, and then with deep partial thickness, it's red to white, moderate edema, and slow cap refill. A lot of pain still. No, they may have a blister, but usually it's rare. They have eschar, which is soft and dry, and it's not leathery at this point. When we get to full thickness, remember the L's for leather eschar. It's going to have a lot of different color variations. It's going to have severe edema, and then no pain like within the wound, like deep in the wound, but on the edges, they're still going to have pain. Um, they'll have the eschar I talked about. Now, when somebody has eschar and it's a limb or the chest, you're worried about um, uh, compartment syndrome if it's a limb. And if they can't move their chest, they're not going to be able to breathe. Okay, so if they have a circumferential thoracic injury, they're not going to be able to breathe if it's a full thickness burn. And I'm going to show you a picture about that later. Okay, all right, so remember, this full thickness destroys sweat glands, reducing the excretory ability, and the nerve endings also are damaged, okay? Then with deep full thickness, okay, this damages the epidermis, the dermis, the fascia, and the tissues. So it extends beyond the skin, damages muscle, bone, and tendons. Okay, so this is going to be black is the color, right? Look at this. And no pain, no swelling, no blisters, just leather eschar. Okay, so remember to watch out for your 6Ps. So make sure you know the 6Ps. There's this video, Burn Depth. If you want to look at it again, this might help you. I have it in your classroom under your resources for week 10. All right, total body surface area. Now you are going to have to know the rule of nines. I think there's like 4 or 5 questions, and one's going to be like this, like person, and the other ones are going to be written out. Sure, you write it out on your paper because you may miss an area if you're trying to like just figure it out in your head. Just don't do that. It's your final exam. Just there's no shame in writing it out, assigning the percent, and then adding it up. No shame at all. Okay. And there's some quizzes in your resources for week 10 as well, like the Rule of Nines Ninja quiz. Like you can take that one. Okay. Fluid resuscitation. Okay, I'm not going to have you memorize the Parkland formula, but what I do want you to understand is, okay, this is going to be your main priority when somebody has a burn. If they, if there's not an airway, you don't get any indication there's an airway issue or breathing issue, this is your main priority. Okay. The reason is, remember, I told you that their capillaries are going to be leaky all over their body and all the fluid is going into the interstitium. They're going to get really edematous and bloated. So you have to try to keep fluid inside the vascular system. So you put a lot. And I'm just going to give you an example. Somebody that weighs like 70 kilograms is going to need 14,000 milliliters over 24 hours. I mean, that's a lot, right? A lot. And you give the first half over the first 8 hours. You give half of that, so 7,000 over 8 hours. I'm just giving you an example, okay? The goal of urine output, you want 0.5 to 1.0 mLs per kilogram per hour or 30 milliliters per hour, like you were taught, okay? We never give furosemide because it's not going to work. The reason that they may not be perfusing their kidneys is because the blood volume is so low. So that's why we have to give a lot of fluid. So that's going to be your main priority in the early type. The only thing I want to say about the burn type really is that if somebody comes to your ED, they're probably not coming for minor burns, so they're going to need tetanus. Okay, That's important. And you don't need to worry about different um, minor, moderate, and major. You don't need to worry about that. Okay, health promotion. Okay, so tell people to check the water before they get in. And the bath water needs to be set at 120. They need sunscreen and protective clothing if they're going to be outside. Don't drink and do drugs and smoke at the same time. Don't smoke in bed. Don't smoke near oxygen. And don't do this. And I know you probably do this because everything is electronic these days, but be careful. Make sure you have a carbon monoxide alarm and also a fire alarm in your home. Okay, pre-hospital care. Okay, so what you're going to do for minor burns is run cool tap water over the burn continuously for 10 to 15 minutes. If it's a small burn, like on their hand or their arm, small burn. Apply cool compresses if continuous water flow is not available, but running cool tap water is the best. Don't apply ice water, butter, ointments. Don't pop blisters. Cover loosely with sterile gauze bandage and take ibuprofen or acetaminophen for the pain if it's not contraindicated. You want to never run back into a burning building. It doesn't matter what's in there, it's not important. You're going to do the primary survey on any trauma victims in the area. You want to begin cooling within 1 minute, if you can, of a burn injury by just irrigating with cool tap water. No butter. We want to cool for about 10 minutes if it's a large burn. And the reason is you don't want the patient to get hypothermic. And we never submerge burn patients in cold water because they could become hypothermic. Because remember, the skin helps keep you warm, it's an insulator. Okay, so if they don't have that, they could get hypothermic. Okay, so the emergent phase of burns, this is the early phase when all the fluid is going out into the tissues. So they're going to have, I'm looking right here, all the fluid is going out. This is what happens. Um, they have leaky capillaries, so the albumin goes out. Water follows albumin, sodium follows water. Okay, so they're going to have low volume, low sodium, low albumin, high potassium, and high hematocrit because it is hemoconcentrated. All right. Um, and then this is just showing you the sequence, like if they have make sure they have a good airway, check their breathing. If they have an electrical injury, they may have a cervical collar on because electricity can break bones and it can fracture like cervical spine. So remember, keep this on until the provider says you can take it off. Start 2 large bore IVs, very important. And you're going to get the fluids going. Remember, they get a lot of fluids. And then pain management. Again, make sure the airway, this is the emergent phase. They just come in. Look at how all this suit. Make sure they're intubated. They're going to be vented, so they'll need sedation. Anyways, I don't want to really get into the vents, but this is what I wanted to show you. This person had full thickness burns on their thorax, so they couldn't breathe. So the physician does an eschorotomy. Comes and he takes a scalpel and he just cuts the skin open so now the chest can rise and fall. All right. Circulation preventing hypovolemic shock is your main goal if the airway is already taken care of. And remember, electrical burns, get them on a monitor. Um, and then they're going to have high blood sugar because they're under a lot of stress, even non-diabetics. Within 24 hours, burn patients develop a stress ulcer. So you have to get them on early enteral feedings. And remember, we check the residuals to make sure they don't aspirate because they're going to have a paralytic ileus. Okay, so that's important to know. Now, when we move out of the emergent phase, so what's going to happen is they're going to start diuresing. Okay, usually about 36 hours. So they'll diurese, and then the sodium and potassium both go low. Okay. So the acute phase is all about pain management, physical therapy, dressing changes, making sure they have proper nutrition. Okay, when you have massive trauma, your body like needs massive calories and protein to heal. So high calorie, high protein, high carb diet. You need to weigh them daily to make sure they're getting enough food. And then you also want to make sure with a burn patient, we kind of treat it like a neutropenic patient, like don't bring fresh flowers in the room because Pseudomonas grows in water. Okay, so you want to make sure they're not, you're not bringing infection in. Okay, so with debridement, they can do mechanical debridement. This is hydrotherapy. Um, so what you want to do to minimize the potential for infection, no matter what kind of dressing changes they're having, there's two terms you need to know. One is called auto-contamination, and this is when the patient's own flora overgrows and can spread to other areas. So like if you go in and the patient has two wounds, make sure you're not auto contaminating. So make sure you're changing gloves for different areas of the body and between old and new dressings to prevent that. Cross contamination is when you bring other people's germs to somebody else. So this could happen if you use like a Dynamat and you're going room for room without cleaning the cuff off. So don't do that. In burn units, everything is kept in the room. You don't transmit things from room to room. All right. And so to minimize infection, make sure the equipment's not shared among patients to prevent cross contamination. No plants or flowers. Do not permit them to eat raw fruit or vegetables. And then visitors are restricted if the patient is immunocompromised. All right. So early detection is important. They have So another thing that they can do to debride is they can use ointments like Mafinide. It gets in there and like breaks the eschar off. It's really painful though. You have to make sure you medicate your patients before you do any of that. And there's different surgeries they can do. They can do grafts, but you have to get all the eschar off so that the grafts can be put on. And then in the rehab phase, this is where they, focus on psychosocial, and this begins when the wound has healed. Okay. Now, even though the wound is healed, it doesn't mean like the treatment's necessarily over because they can get contractures and they can also get like hydropertrophic scarring. So they would wear these like elastic pressure garments. Okay. And then these can be painful, not painful, uncomfortable as well. And they would wear them 23 hours a day. So here's like an example of some of that. All right. Who's got questions for me?